Hi, this is Dr. Bueller. I'm going to be giving you a very brief overview of male sexual anatomy. This is a review. You guys have probably had this in undergrad, but I just want to make sure that you're ready for the pharmacology and the drug targets. We're going to start with male sexual and urinary anatomy. The reason I'm going to talk about urinary anatomy is I want to make sure that you guys understand the role of the prostate in both. So we're talking about the path of urine from the kidney to outside of the body. The urine is made within the kidney. It is transferred through the ureter, which is not the same as the urethra. The ureter is a tube that's going to transfer the urine into the bladder itself, where it's stored. There's a bladder sphincter that's going to keep urine from leaking out into the urethra. And when that bladder sphincter opens and the bladder muscle walls contract, the urine is then squirted or released into the proximal urethra, which is the tube that is coming straight out of the bladder. The proximal urethra actually travels inside through the tissue of the prostate. The prostate is wrapped around it so that if you think of this as a donut, the prostate is wrapped around and the tube of the proximal urethra is going to then travel through the inside of that. In a normal urinary anatomy, the prostate should be relaxed, it shouldn't be swollen, and that area should be opened up enough that urine is able to flow through the urethra and the urethra is not pinched at all. If the prostate itself is swollen or enlarged for any other way, and it starts to impede and pinch the urethra, then it's going to be really difficult for urine to flow. Once flow can occur and goes through the prostate, it'll go through the urethra, which goes through the penis and exits at the head of the penis, at the glands. So I'm going to have some self-quiz questions that I'm not going to go over them in the actual lecture here, but I am going to provide you slides and you can take a look at those. Those will go into the answers. If you are not in my class, then don't worry about it. The answers are contained within the presentation itself. So when we talk about spermatogenesis and ejaculatory anatomy, we're going to share some of the same organs and pathways, but everything before the prostate is going to be separate from the urinary anatomy. So here we have a picture of the testes, and the testes are where the sperm are going to be produced and stored. So sperm, properly known as spermatozoa, are going to be produced by Sertoli cells within the testes itself. And then they're going to be transferred and stored within the epididymis. You don't need to memorize that. They're stored within the epididymis, but we know they're in there and they're just waiting for ejaculation to occur. If ejaculation occurs, then they're expelled through a tube called the vas deferens and then out. We're going to see that the vas deferens starts to hook up with the rest of the anatomy. So here we had the testes that we had talked about before, the epididymis going to the vas deferens, and the vas deferens is actually quite long. It's going up around the bladder and down to where it's going to then hook up with the seminal vesicles. The seminal vesicle is going to have excretions in it or fluids that are going to be able to mix in with the sperm that are coming through the vas deferens. So at first they're just sperm, now they mix with the fluids. Now they're going up through here, they're passing through the seminal vesicle, they're passing through the ejaculatory ducts. So the ejaculatory ducts open up, and from then the semen is going to be able to go into the proximal urethra, which is very, very close to where the urine is going to start to come into the urethra as well. So at that point, you're going to be able to have the sperm or the urine going through into the urethra and then out the same direction. So from these ejaculatory ducts, sperm are now going to enter the proximal urethra. At this point, when the semen starts to come out and we're adding those fluids and secretions, we're going to have the sperm coming up. We're going to add fluids from the prostate, from the ejaculatory duct, from the urethral gland, and all of these secretions plus the sperm are going to form semen. So all of those together are what we term semen. It is then going to be able to exit the body through the urethral pathway, which is shared with the urinary tract. So the semen exits the body upon orgasm by the contraction of various muscles, including ones in the prostate gland. So that's going to be pushing semen out through the distal urethra. If the prostate is unfortunately not able to contract rhythmically or properly to push out the semen, then you would not have the ability to have proper ejaculation. So now we're going to talk about the anatomy of erection. This is important because this is where we're going to have our drug targets. So when you look at a cross-section of the penis, here on the bottom left side, we're going to see the cross-section of a non-erect or flaccid penis. Now, when we look at the middle of the penis, we have these areas called the corpus cavernosa. And these areas can be filled with fluid, and the fluid is coming from blood vessels coming in there. Normally, these areas in the corpus cavernosa are very small. They're held small because of muscle cells. Those are lining these regions and holding them, contracting and holding them small. I'm going to take blue here. I'm going to draw muscle cells around each of these. As long as these muscle cells are contracted, the corpus cavernosa cannot open and blood can't flow into them to a great volume. So in order to get blood flow in order to cause volume increase, and then, of course, cause rigidity, we're going to need to open up and relax those smooth muscles. So here is what we need to do. We need to relax those muscle cells. So how do we do that? Any smooth muscle can be relaxed by being exposed to nitric oxide. And so we see up here at the top that nitric oxide can be released onto a muscle cell. It's made and released from nerves, not from the muscle itself. But nerves are going to release nitric oxide on. That's going to then cause the muscle cell to produce cyclic GMP. Cyclic GMP is the actual molecule that causes the muscle relaxation. So it's being released within the muscle cell itself. It's going to cause relaxation. The GMP also then has to be broken down like anything else. It gets broken down with an enzyme called PDE5. There are several subtypes of phosphodiesterase. In this case, the one in the corpus cavernosa is phosphodiesterase 5. That's important because there are phosphodiesterases in all sorts of other parts of your body. And if you're going to utilize a drug to try to manipulate phosphodiesterase, you don't want to affect every part of your body. So using something fairly specific for PDE5 is going to give you the effects that are fairly specific for erection. So to have erection, you're going to want to have a good balance between the effects of nitric oxide and the effects of PDE5, so that as long as you have nerve stimulation continually releasing nitric oxide, you can keep your cGMP levels up. Do that, you're going to keep your relaxation occurring, and you're going to allow blood flow in, and erection will occur. So the mechanisms that cause nitric oxide to be released from the nerves are generally physical or psychological stimulation. Stimulation physically of the genitals or any tissue that's going to be excitatory. And psychological stimulation in terms of, getting in the mood. So physical and psychological stimulation, and usually a combination of both, will cause the nerves to release nitric oxide onto the smooth muscle cells, causes cyclic GMP, and as long as you have a lot of nitric oxide continually being released, then your nitric oxide levels are going to be greater than your PD5 breakdown, and you're going to keep a good level of cyclic GMP. And you're going to continue until the stimulation ends and nitric oxide levels go down. Then you're not making as much cGMP. The PDE5 is getting rid of the cGMP that's already there, and now you're going to cause constriction again, and you are going to have that loss of erection. So it's this balance between the nitric oxide and the PDE5 that's going to say whether you have an erection or not. So let me show you here the places where we can have pharmacological targets. If we come in and increase nitric oxide, or increase the release of it, or give nitric oxide directly into the local tissue of the penis, that's going to increase cyclic GMP locally, and it will produce erection. The other choice is to decrease the activity of PDE5. That also increases cyclic GMP because that's backed up and causes erection. When we first started treating erectile dysfunction with pharmacotherapies, nitric oxide was actually injected with a syringe into the penis tissue. For kind of obvious reasons, that was not an optimal route of administration. And the nitric oxide was very short-lived at that time. Now we are going to look for something that's orally bioavailable and that's going to last longer. So those drugs are really what we're using now for treating erectile dysfunction. So when you hear about something like Viagra or Cialis, those are going to be PDE5 inhibitors. There is out there an incorrect belief that these will actually cause erection themselves, but they're never going to cause erection unless nitric oxide is being released. If cGMP is not high, blocking PDE5 isn't going to do anything. So stimulation has to occur for PDE5 inhibitors to cause erection. So that's the end of the male sexual anatomy for us, and then we're going to go ahead and talk about female sexual anatomy next time.